Oh, these are mine.
There's instructions behind the whiteboard there or something.
Sure, it's fine.
Show the name. I can't see.
Well, it's being recorded.
Sure, we'll get there.
Kia ora koutou. Ake ahi Māori e. Welcome to the first of our bioethics centre seminars for the second semester, 2024. Just to let you all know that we record these and they are available for viewing through links on the public part of the centre site if you're interested in seeing things again or interested in recommending them to people you know who might have missed the session. Welcome to our online attendees. If you haven't come to these before, we have a very standard procedure. So we start off with a presentation, this week given by Tone, and I'll introduce Tone in just a second, who will speak for something like 25 to 30 minutes, or maybe a little longer. And then there will be a time for Q&A. After that, we generally start with those of you who are online, and you can either put a question in the chat, and we'll try and monitor that as we go along, or you can raise a hand, and then Taryn we can unmute you, and you can ask your question using your own voice. And then, or somebody else's voice, if you have that capacity. We also take questions from the floor here, and hopefully our audio setup is good enough for you to hear any discussion going on in the room, as well as discussion that's going on more directly right in front of you. If you have any problems hearing, please raise a hand if you're online, and we'll try to do some adjustments here. So if you're having trouble hearing me, do let me know. If you can't hear me at all, perhaps you can let me know as well, but hopefully everything's okay. This week, Taryn, who is one of our colleagues at the centre, is going to be asking this question: is pregnancy a disease? And I've had a long connection with Taryn over many years. She was a PhD student of mine. I was very lucky to have her as a PhD student, and it's great that she's now part of the full membership of the staff here. And Taryn just has a way of raising these questions and then digging away at them and getting to some really deep places. And this title, although it's not familiar to me as a specific area of interest, is extremely familiar to me from her PhD, which was on the question of the nature of disease and what would count as a disease and what not. So Taryn is coming home a little bit from that point of view. And I'm going to hand over to you now, Taryn, and we'll see what's going on with this question. Is pregnancy a disease?
Thanks, Neil. Yeah, so welcome. Thanks for coming along, everyone. So as Neil said, I started my PhD was on the nature of disease, and specifically I was asking whether homosexuality was a disease. And then a paper came out by, I think it was Swedish, should have looked this up, Swedish peer, who, I don't know how to pronounce their name, so I'm going to call them Smajdor and Räsänen. And they argued that pregnancy was a disease. And, you know, I thought, this is a bit crazy. Like, seriously, if there's something that's not a disease, it's going to be pregnancy. So I didn't even want to take the article seriously. I thought it was maybe just a bit ridiculous. But anyhow, I read it. They get a lot of stuff wrong, but they also get some stuff right. So I think that it's worthwhile looking into the argument into more detail. So on top of my interest in the status of disease, since I had my daughter 3 years ago, something that I've become interested in is pregnancy and the rights of women when they're pregnant and in birth. And I haven't done a lot of academic research on it, but I've listened to hundreds and hundreds of hours of podcasts on this sort of thing, you know, like when you're awake at 3 a.m. in the morning. So this article was like right up my alley. When a colleague mentioned it to me, yeah, I thought this is awesome. This is an area that I want to get into. So Smajdor and Räsänen, the Swedish woman, they argue that pregnancy is a disease, and they give both conceptual and normative reasons for it. I'm going to focus on the normative, but you know, just for the sake of thoroughness, just have a quick look, have one slide at the conceptual reasons. So, you know, when we think about conceptual analysis, we think, well, what counts as a disease? So they say, well, pregnancy is risky, right? It's, you know, it's harmful, like diseases are. And it's not just that you have a bit of nausea in the first 12 weeks. No, people die from being pregnant. It's caused by a pathogen and external organisms invading the host's body. I mean, I guess that depends on your perspective. But one of the interesting things about their claim is that they say that both wanted and unwanted pregnancies are diseases, right? So if you've planned this pregnancy, you want it, they say, yep, cool, it's still a disease. No one else has argued this before. People have argued that unwanted pregnancies are diseases, but not wanted pregnancies. They say it can be treated medically, and the risk of getting pregnant can be reduced using prophylactic measures. Right? So those are all the ways in which pregnancy is like a disease. Then they admit that, you know, there are some ways in which pregnancy isn't like a disease. And I think the one that will, you know, most of you will think of first is that it's functional, right? It's a function of our body, well, of a woman's body, but it's also a function of the species, you know, the carrying on human life. The vast majority of scholars in this area, well, everybody agrees that function is it's a really important part of disease. So if it's going to be disease, it has to be a dysfunction, right? Seems kind of common sense, but then there's so much debate about what counts as function. Is it teleological? Is it etiological? And we could get bogged down in, you know, really technical philosophy of science. And I'm not going to do that today. I've been there, done that, and I do not wish to go back to it quite frankly. But what they say is that there are values baked into this notion of function, and that means that we should look for a definition of disease that doesn't have function in it. And this has been done. So Rachel Cooper has done this. Personally, I don't think that they really understand Rachel Cooper's account of disease, but we're not going to get into that today. They're just getting around it saying, well, you know, yeah, it looks functional, but does functionality or dysfunctionality really need to be a necessary component of disease? And they say, no, it shouldn't be, because there are values baked into what counts as function. Currently required for human survival, so for the survival of the species. And then they say, oh, there's this thing called ectogenesis. So that is having a fetus raised outside of the womb, right? So the idea is that, well, we don't need to be pregnant anymore. We can, put them in a lab, and a baby can grow in a lab. And Smajdor, one of her main themes is in the moral defense of ectogenesis. So she's really keen on looking into having babies raised outside of the body, or fetuses raised, however you want to put it. So they say, well, if we can have ectogenesis, then we don't need it for human survival. So maybe it's a disease. And then they look at this idea of valued. Wanted pregnancies are valued, right? And it seems that dysvalue is a really important part of disease, which would suggest that a wanted pregnancy couldn't be a disease. And then they do something really interesting, but I don't have time to get into it today. They say, well, sure, you can value being pregnant. And at the same time, you can disvalue certain parts of it. You can disvalue the morning sickness and the not being able to, walk around properly because your lungs are all squished up and that sort of thing. So they say, having a wanted pregnancy doesn't mean that we can't disvalue parts of pregnancy. And then they say, well, look, this is like lots of other diseases. Cancer, Okay, cancer is a disvalued thing, but there's loads of evidence to say that people value the experience of having cancer. Like they get something out of it, right? And so they say, well, look, it's not so different here. So these are the conceptual reasons why they say pregnancy should be classified as a disease. There's the ways in which it's similar, and then they acknowledge that there's differences, but try to get around. Not my focus for today. I'm going to focus on the normative reasons. So their argument is that classifying pregnancy as a disease would lead to better treatment for women. This is the paragraph that I'm going to focus on, so I'll give you a minute to glance over it. Right, so I've sort of split this into 2 points. I'm going to begin by considering the claim that pregnant people's preferences are ignored, and that they're ignored because pregnancy is normal, because pregnancy is not a disease. Okay? And then later on, in the second half, I'm going to consider the claim that construing pregnancy and childbirth as a disease will positively reorientate the doctor-patient relationship. Okay? So the first bit, so they say pregnant people's preferences are ignored because pregnancy isn't classified as a disease. I think that they pick out something really important here. Oh, we seem to have... There we go. there's quite a lot of evidence suggesting that, pregnancy is one of these areas in which people just aren't listened to that well, where the health professional involved sort of takes over. And this especially happens in childbirth. I guess there's obvious reasons for that. It's bloody painful and you're in this heightened sense of, urgency. And so, there is a sense in which maybe you just go with what the doctor or the health professional says. But it's not only in childbirth, it's throughout pregnancy. We sort of have this old-fashioned idea that we should defer more to the health professionals than we do in other settings. So there's some quotes here. They were from a Dutch social media. So these guys here, they put out this this request for people to report their traumatic birth experiences on social media. And they got over 2,000 responses. This is the sort of thing that they saw. They're deliberating an episiotomy. They're not asking the person involved, what do you think? What do you want? It's just the health professionals talking about it, around here. The woman saying, I'm in so much pain, I must be dilated. And the doctor's saying, no, you can't be, And then, boom, the baby's born a few minutes later. Requests for pain relief being ignored as well. Okay. This happens around the world. So this is some Dutch quotes about it, but it happens around the world and from, the moment someone becomes pregnant. So it is a problem that pregnant people aren't listened to. And Lyell talks a lot about the culture of birth that is expert-centered and not patient-centered. And something that I'm not going to have time to get into today is the difference between midwife-led care and obstetric-led care. I don't want to get into it. It's very easy to set up this dichotomy where the midwives are all about the patient, the pregnant person, and the obstetrics are these horrible people, who are just all totally medicalized and are not interested in the welfare of the person involved, which I think is false. But in any case, a lot of health professionals involved in healthcare aren't, they're not truly patient-centered. It's very much about the expert involved. And then others, Cookler and Wayne, say that the medical professionals have this epistemic privilege, and the pregnant people are reduced to passive roles. So Smajdor and Räsänen, they say that pregnant people aren't listened to. I think they're right on that count. So they do pick out an important problem. But they go further. Oh, what is this? Oh, I see what I'm doing. They say that pregnant people aren't listened to precisely because of the normalness, because pregnancy is not a disease. I think there's possibly a kernel of truth to this claim. I think, maybe they're onto something here. We do think that when people request a cesarean or pain relief, there is this notion in society that they've failed somehow. And even if we don't think that, a lot of people who have had cesareans, they do feel as if they have failed. So maybe we need to change our ideas of what counts as a successful birth. But to say that health professionals ignore pregnant people solely because, or precisely because pregnancy isn't a disease, I think is far too simplistic. So here are some other reasons. Misogyny. Women are expected to sacrifice themselves for their children, and this includes enduring pain during childbirth. I think it's unquestionable that parents, but especially so mothers, are expected to sacrifice themselves for their children. You know, and if there's any chance that having pain relief is going to impact the well-being of your baby, others shouldn't have it. And women feel that way as well. So I'm not trying to blame men, here, even though I put the word misogyny there. But I do think that we have this idea that pregnant people are supposed to suffer. They're supposed to sacrifice themselves for their kids. And so if they ask for pain relief, they don't need it, well then we won't give it, because that's what childbirth is about, and that's what motherhood is about. It's about self-sacrifice. Medicalisation, I alluded to it before, that pregnant people are passive. They play this passive role, and of course this happens across all of medicine. There is a sense in which the doctors and the midwives are experts here. But I think when you combine it with these misogynistic reasons why people aren't listened to, it becomes especially salient. We need to be doing more to try and balance the expertise involved in here. There's issues of obtaining informed consent, right? So you're in a hell of a lot of pain. Is the pregnant person competent to make a decision about that stage? Again, kind of wrapped up with this misogynistic stuff, because women are supposedly less rational than men. That's what some people argue. So you're exhausted, you've been doing this for 12 hours, 24 hours, you're in pain. I think it's arguable, and some people completely disagree, but I think it's arguable that in that situation, some pregnant people, some labouring people aren't competent to give consent there. And so, sometimes it might be appropriate for a medical person to step in without consent. This final reason I've been struggling with. So preferences, so pregnant people aren't listened to because what they want are harmful or non-beneficial to either themselves or to neonatal outcomes. So a person who's pregnant with twins, who's previously having had a cesarean, wanting to have a home birth, does seem like there's some risk involved there. Should we listen to that woman? Or a woman requesting a cesarean for non-medical reasons. So just because she wants it, there's no medical indication. There's argument that that's harmful or non-beneficial to the fetus. So should a woman be able to choose things like that? Again, happens in all areas of medicine. Yeah, I've been struggling to sort of put this into any formal structure, but I've sort of put it into 3 points here. I think we need to do some work, or I need to do some work on exactly what is meant by pregnant people aren't listened to. Other times it's talked about pregnant people aren't being respected. But what does that mean? not being listened to, I think, just being ignored is not okay. But I think you can still be respected. Your choice can be respected, and you don't get what you want. Right? So I think there's a lot of loose language around here that needs to be pinned down a bit more. There are empirical issues about what's harmful and what's non-beneficial. Again, happens in all areas of medicine. So things like, should a woman who's at 42 weeks gestation be routinely induced because the placenta is at risk of calcifying? Or is that kind of, because we've got so much technology enabled us to detect these things? Should we just wait and see how that woman is going at 42 weeks? So there's lots of mixed empirical evidence about what's harmful. Very basically, what I mean by that last point is simply that it's not only because pregnancy doesn't have disease status that pregnant people aren't listening to. It's all these reasons too, right? Including because sometimes people want what's harmful or what's not beneficial. Right. So there's another problem. Unnecessary intervention. To say that health professionals don't listen to pregnant people who want pain relief or who want, say, a cesarean section doesn't account for the very, very high rates of unnecessary interventions. And by interventions, I mean things like induction, so giving women medications to bring her labour on, episiotomy, a forceps or a vacuum delivery, C-sections in there as well, and then after the birth to give syntocin to birth the placenta. So all of these things happen really, really commonly and also often unnecessarily. So in the past, there's been a lot of worry about childbirth and doing too little too late, right? So we can think of the global south where women are dying because they're not giving the medical interventions that are required. A really big problem that's been emerging over the last, 10, 20 years is this idea of too much too soon. So doing too much intervention is a sort of precautionary approach. Here's an example of that. Caesarean sections, you can see in low income countries, quite low. And then high income countries, they sort of sit around the middle. In middle income countries, there's a lot, like, can't see it here, but it's like what's over between 50 and 60% in South America, right? Of births are caesareans. New Zealand sits, from that data, sits in the middle, somewhere just above 20%. Oh, I think, no. Oh, I must have taken it out. So I looked up some more recent data. That's 2016. 2022, which is the latest data in New Zealand, the Te Whatu Ora said that 32%, so that's nearly a third of all births in New Zealand were C-section, and that was the highest rate that we've ever had. And this increasing rate of C-sections is increasing around the world. Okay? There isn't consensus about what the optimal rate of C-sections is. They used to say it was around 9%. So 9% of births Caesareans are actually necessary for the well-being of the mother and the baby. You know, in New Zealand now we're doing nearly, well, over 3 times that. As I said, there's no consensus, but around 9% seems to be the idea. Even though there's no consensus, just about everybody, including the World Health Organization, say that the amount of caesarean sections needs to be reduced. So, and you know, there are lots of unnecessary caesareans being performed in high and middle income countries. And at the same time, in some of these low income countries, we need to up the rate a little bit. So what's my point here? If health professionals are ignoring pregnant people's requests because pregnancy is not a disease, why is the intervention rate so high? So they're saying pregnancy, so Smajdor and Räsänen say doctors are not allowing women to have interventions like C-sections because pregnancy is normal, because it's not a disease. Totally conflicts with, you know, these very high rates of intervention that we have here. So far I've talked about the reasons, the other reasons why pregnant people aren't listened to. And then I've talked about this odd sort of conflicting claim about the very high rates of interventions that we have around the world. So now, let me go into time. Let's move on to the second part of the quote. So here they're saying, if we were to classify pregnancy as a disease, then this would give us the opportunity to reconfigure the relationship. So it would be positively reconfigure it. It would make it better. I mean, I just think that's wrong. Firstly, things like informed consent. It doesn't matter whether something's a disease or not, right? You have to get informed consent whether someone's having a nose job because they can't breathe properly or because they want it for aesthetic reasons. It doesn't matter. But going back to my PhD with Neil, there's always a but involved, right? And I do think that there is a kernel of truth for what they say. So let's try and give them the benefit of the doubt. Diseases are the sorts of conditions for which medical treatment is appropriate. Now, that doesn't mean that only diseases are the sorts of conditions for which medical treatment is appropriate, but there does seem to be a link between disease and medical treatment. So, if we classify pregnancy as a disease, then health professionals might be more amenable to providing things like pain relief. And so in this sense, there is a link between disease status and having your preference respected. But, so the previous slide, I talked about how if a person wants an intervention, a disease status might mean that health professionals are more amenable to providing it. So, you know, preferences will be respected. But what about people who don't want intervention? It's not going to help them. It's not going to help their preferences be respected. And this is highly problematic because, as I talked about before, the rates of intervention are huge. Health professionals are keen to get in and move things along. You might say that they can be quite risk averse, especially when it comes to the health of the fetus. So you know, Smajdor and Räsänen, they're onto something. You know, the woman's in pain, and the doctors are saying, it's normal, it's pain, you know, mothers should self-sacrifice. Let's not do anything for the mother's well-being. But when it comes to the fetus, they are really keen to just get in there and save this baby, or get this baby out, let's say. Not save, because it probably would have been fine anyhow. So, put bluntly, and I don't know what the statistics are, and I've tried in vain to find them. I would say that the vast majority of women would prefer to have less intervention than more. They're often not listened to. For this big chunk of women, classifying pregnancy as a disease is not going to help them. It's going to make health professionals more inclined to move ahead. Oh, I've gone into some of it here. So on this slide, I've talked about some of the reasons why health professionals don't listen to people and whether this would help. Baron, with respect to misogyny, she says, how is classifying pregnancy as a disease going to help with these misogynistic reasons? She says it's the gendered views that need to be challenged, not the disease status of pregnancy. And I agree, but also I think that changing the disease status may help to challenge these gendered views about things. So, sort of playing a bit of devil's advocate here, if pregnancy was a disease, it might help to get rid of some of these old-fashioned ideas about self-sacrifice and that sort of thing. I also talked about the problems of getting informed consent. Would classifying pregnancy as a disease help with that? Possibly. I mean, it might mean that health professionals take pregnancy more seriously and, you know, get more into advanced planning, that sort of thing. Is it going to help with the expert-centered nature and the medicalization of pregnancy? No. So although there are some ways in which pregnant people's preferences would be respected by classifying pregnancy as a disease, I do think that the downfalls outweigh the advantages, right? Also, there are other ways of doing these things rather than classifying pregnancy as a disease. We can improve advanced planning for pregnant people without having pregnancy as a disease. Right? We just need to talk about it a bit more, you know, beforehand. So I don't think that there is sufficient reason to keep classifying pregnancy as a disease. So here's my sort of final point. Classifying pregnancy as a disease might help those people that want intervention, but it's not going to help those who don't want intervention. And it seems to me a large chunk of pregnant people don't want intervention or would want less intervention. And then I wrote this piece with Brad Partridge, who's in Australia. He sent this article to me in the first place. And he put it really well, I think. He said that Smajdor and Räsänen say that better treatment is about listening to preferences. But actually, their view of better treatment just entails more use of medical technologies during pregnancy and childbirth. You know, I talked about the ectogenesis before that Emma Smajdor is really interested in. This is what she wants. She wants technology in childbirth. And I think their argument in favour of classifying as a pregnancy as a disease really does they're not upfront about the reasons why they want pregnancy to be classified as a disease, put it that way. They are interested in medical technologies in pregnancy. That's my last word. Overtreatment of pregnancy is a major problem. Giving pregnancy disease status won't help with this. Other ways of debunking sexist views and improving advanced planning. So, insufficient reason, normatively speaking, so I haven't been thinking about conceptual stuff, to classify pregnancy as a disease. So that's me. I've spoken for too long.
We'll just stop the share.
Oh, yeah.
So we can see. So thank you very much, Tara. And as is our tradition, I'm just going to see whether anybody online has any questions. We have, oh, thank you, Angela. She says this is International Birth Trauma Awareness Week. I wasn't aware of that. Thank you, Angela.
Well, the other thing, just on that, and this is from podcasts more than academic reading, is that a lot of the trauma that people talk about isn't like, you know, their baby dying or having a hysterectomy or that sort of thing. The traumatic thing is not being listened to. So, yeah, we can think more broadly there as well.
It looks like Angela has a question. So would you like to just can you speak, Angela?
I can speak. Thanks so much. That was can you hear me?
Yep.
Yes, we can. Thank you.
I really enjoyed that. A really thoughtful analysis, and I disagree with the original paper as well. So I was right on board with all that. And I mean, you might also be interested that the theme for Birth Trauma Awareness Week this year is consent. And you're right that a lot of the trauma comes from a sense of being dismissed and ignored. So I thought your comments were really timely in that sense. So the thing I wanted to ask about was if you could comment on the idea of the dual patient model in obstetrics, because I feel like that's where a lot of this comes from, right? And it's not something that is acknowledged in the literature much anymore. And my sense is that it seems a little bit outdated. So that is the idea that birth healthcare providers, so, you know, obstetrics or midwives, actually see themselves as treating two patients. They're treating the woman and they're also treating the fetus, and they're conceiving of the fetus as a patient with moral interests, even if it doesn't have legal interests. And that really seems to clash with the idea that the fetus is a pathogen. So the whole framing of disease, pregnancy as a disease seems to be totally out of line with the kind of the moral framing that's at play in obstetrics. And I think that dual patient model is often what is causing healthcare providers to dismiss or ignore or discount women's own perspectives because they're weighing up that perspective, but they also feel like they're defending the interests of a vulnerable fetus that can't speak for itself. Thanks.
I had this as one of the reasons why pregnant people aren't listened to. So pregnant people aren't listened to because the health professionals feel an obligation to protect the fetus, right? But I think that comes under this idea of self-sacrifice. The pregnant person should sacrifice herself or themselves for the sake of their baby. And the other point is that, as I mentioned, health professionals won't intervene, less likely to intervene for the benefit of the mother, but much keener to intervene for the health of the baby. Something that so we used to talk, and I think some people still do to some degree, about maternal fetal conflict. So when the mother wants something that is bad for the fetus, potentially harmful for the fetus. And it just doesn't seem to, it's kind of it's a contentious, or how can I put it? it raises people's hackles when perhaps it should be better thought about as the mother-fetus relationship, because 99.9% of the time, the mother wants what's best for her fetus because she gets a secondary benefit from having a healthy fetus. So very rarely are you going to get a situation where the mother says, no, I'm going to do this, even though, it's going to be terribly harmful for my baby. And then there's also lots of, the empirical issues about what counts as a potential harm. So, yeah, I agree. So having this idea that the fetus is a pathogen versus, the fetus is this vulnerable moral agent and we need to protect it is, there's lots of unpacking to do there. And I think Smajdor and Räsänen would say the fetus isn't a vulnerable moral agent, or, well, actually, the fetus doesn't matter. We should be doing what the mother wants. I think that would be their view. Yeah.
Mike.
Great talk, thanks, Karen. I was trying to think what the pathogen is here too, and I don't think it's the fetus. I think it's probably guys.
Yeah.
I think it's probably sperms.
Yeah.
And so, but it is, and because I was wondering whether they discuss the implications of this argument for termination of pregnancy, because it seems like one treatment here is termination of pregnancy. If it's a disease, perhaps that means that, sort of in an imaginary world where you can just sort of declare something disease and therefore establish all the funding goes along with that. Think about how it might work in the States. It could mean that this is something that that gets better funded because it's regarded sort of more clearly. Obviously, it's not going to. To do that, I imagine this people would reject this idea. But I just wondered, do they talk about?
They do. They say in contraception as well. They would say that classifying pregnancy as a disease would enable easier access to contraception and abortion. And I think maybe they're onto something there.
But so contraception seems to figure what that works well against the pathogen that we're talking about. Termination of pregnancy, if we say the fetus isn't actually a pathogen, then it's doing something slightly different, perhaps, and so I was thinking perhaps the fetus is more like a sort of a symptom or something, so it's some symptom treatment or something. I mean, this is, I suppose, getting more into the conceptual side of things a little bit more. But anyway, I was sort of thinking in terms of your argument, it might be quite good to, well, maybe you said this and I just missed it, but I suppose you're assuming that the conceptual case is made successfully and you're assessing the ethical implications. Is that right?
Yeah.
Because you couldn't, I don't think, or be pretty in position to say for ethical reasons.
Yeah, so it doesn't fit conceptually, but we're going to do it. Yeah.
Yes, that's just Angela following up on, I say just Angela, that is Angela following up on her earlier point. Do you want to say anything about that? Don't need to frame the interests of women fetuses.
Oh, I was just saying, I agree with you that I don't think it's helpful to think about the woman and the fetus's interests as in conflict. I think it's better to conceive of it as everyone's committed to the best interest of the fetus, but just like parents and health providers might disagree about what is in the fetus's best interest, there's disagreement sometimes between the woman and the health providers about what's necessary.
Yeah, and I don't want to vilify these health providers either, because they do see some terrible things, and if you were in a position, you were, say, an obstetrician for high risk pregnancies and you were seeing these horrible outcomes all the time, of course you would want to intervene. But it does seem that, there's a lot of very over precautious healthcare providers around.
So I've just, sorry. Okay, we have two. I can always ask Tone afterwards. Emma and then Janine.
That's probably more of a technical question. I don't even know if you really answer it, but I just observed in the graph that you showed, the low, middle, high income countries.
Yeah.
And that the World Health Organization said the ideal rate of C-sections is about 9%. But that's in all of the low income countries are currently at, but they've got bad, poorer maternal outcomes. So I just wondered what your thoughts.
I think that's probably why they used to say it was around that level, but that it's not anymore. There's no one who is willing to like put a figure on it anymore. Put it that way.
It's quite arbitrary.
Yeah. The other thing is that although that graph had, was classified low, middle, high, it really depends on the area or the social the socioeconomic status that the individual's in, because in parts of the US, where it's quite deprived, those have implications as well. So it's not as simplistic as yeah.
Janine.
I was lost my train of thought, but I've just come back from the US, and one of the things that struck me was all the signs that say birth injury, call this lawyer. And it doesn't drive things as much here, but I think the sense of responsibility that the healthcare provider carries for the mom and the baby and the fetus, and it doesn't hold up in American court if they say, well, the mother said she didn't want a C-section, and so we didn't push her really hard on it. They're like, well, now you have this injured baby and it's your fault, you should have. And so it's this duality of who's responsible and who's going to carry the responsibility afterwards if you have a lawsuit, happy countries.
Yeah, but I think so I think you're right. So one reason why health professionals might intervene is because they're risk averse, and that's either because they don't want a bad outcome or because they don't want the lawsuits around it.
Doing something is seen as better than not doing something from the public. You rarely get sued, a lot less in the US if you did something that turned out badly than if you didn't do a C-section.
I would be interested in what Angela, is she still there?
No,
she's gone. I know that Angela gave a talk a while ago about birth trauma within New Zealand and activism, and I don't know, but and maybe it's just because of the bubble that I'm in, but it seems to almost be the opposite way. Like people get really angry when you do something that they didn't want to happen. Yeah.
So maybe we've got time for one last question, which is mine, unless anybody else. So I'm just interested. I know you didn't want to address head-on the conceptual issues, although it's a bit difficult to get away from. What's the relationship between the two claims, though? So one claim looks like the standard, is it a disease? And the other one looks like, would it be better if we thought it was a disease? What's the connection they think between those two claims? Because normally you'd say, just because it would be better if something was classified in this way or was ontologically thought of as this kind of thing, doesn't seem normally to be a very good reason for actually.
So they do think that conceptually it can be classified as a disease.
So is that a required part of their argument?
I don't think they make it clear that it's required, but they say they give conceptual and normative reasons why it should be classified as a disease. But they don't say it has to be conceptual and normative.
Right.
Yeah.
So just one quick follow-up. Given that on that basis, it's puberty a disease?
Yeah.
Yeah.
as aging a disease. And yeah.
Infancy diseases, any life stage.
Yeah. The other interesting thing that they talk about is that they say that pregnancy is not normal, and even for women of childbearing years, it's not normal because women aren't always pregnant. Like you're pregnant for a few years of your life, but it's wrong when you think about the capacity to be pregnant rather than the actual being pregnant itself.
Certainly can't be sufficient, can it?
Efficient.
It can't be sufficient.
Sufficient, no.
Because nearly everything is not normal in the sense of taking up most of your time.
Yeah.
I would just off the top of my head.
Yeah.
Yes, sleep is not normal.
Yeah.
Come on, guys, half the time you need to be asleep. Then we'll. Okay, well, just before we finish, are there any final points or questions from those online? No, that's absolutely fine. Oh, yes.
No, I'm not have a question, but just want to thank because I just want to introduce myself. I'm Anne from the Chinese University of Hong Kong, and yeah, hi, and thanks Josephine for actually introduced to us this very insightful forum and also seminar series, so that I have the privilege to join this section. I enjoy the presentation very much. So I just want to say thank you to you all for allowing me and also my team. Later on, we probably have more members to join the series. I know that this is actually an ongoing series in the coming semester. So thanks for having us here.
That's fantastic. Do you get our emails, Anne, and you know what's coming up?
Yes, actually we were included to the mailing list. So my center, I forgot to tell you that from the Chinese University of Hong Kong, and also I'm the co-director of the Center for Bioethics. So that's why I'm also like here and also be interested in joining this section. And our center should be in the mailing list. So I trust that we shall receive more details and also about the upcoming seminars and also events.
Well, that's fantastic, and a huge welcome, Harimai, to this series, Anne. And if there's anybody there, sorry, this is a bit of a anybody there who has a seminar they would wish to give, please contact Josie, who's the organizer, and she'll be totally delighted to hear from you. So that's wonderful. And in fact, this is a great opportunity, before I thank Taren, to just mention that next week, our speaker is Professor Martin Wilkinson, who is a professor in the politics department in the University of Auckland, but has a long-term friend of the centre and does a lot of work related to the kind of thing that we do. So that should be very interesting, and anybody else who's either listening to the recording or listening out there right now. So, Taren, thanks very much indeed. Everything I was predicting, a really deep dig into a very interesting and it seems odd that anybody would say that at first, but once you start thinking about it, you can see all sorts of things that might be going on. So, thank you very much, Ngā nui. Thank you very much, everybody online. And thank you very much, everybody here. See you again, same time, same place next week. Kia ora. I'm going to stop the recording.